Good morning, good afternoon, or good evening, wherever you are in the world. We are delighted to have you join us. And the title of today's webinar is Choice and Initiation of GnRH Analog Therapy for Central Precocious Puberty, with emphasis on long-acting administration. My name is Martin Savage. I'm speaking to you from London, and these are my disclosures. And today we have the honor of Professor Karen Klein giving the presentation. Karen is an authority, a world authority on disorders of puberty, and notably on the management of central precocious puberty using GnRH analog therapy. This is the international committee which supports this series of webinars. They come from the Child Growth Foundation in the UK, APES in Malaysia, and in Australia, also from the Italian Society of Pediatric Endocrinology, and from SLEP in the Latin American Society, and from the British Society. And these are the links and partnerships which have been established by Medea, the organizer of this webinar, and we're very grateful for the support of these organizations. This independent educational program is made possible thanks to educational sponsorship provided by Ipsen Pharma. The potential reach of this type of webinar is really striking, and today we have 380 registered participants from 53 countries around the world. So this is an enormous opportunity for instructive and important educational communication. The learning objectives are to understand the indications for initiating GnRH analog therapy and its schedules and dosage, and the monitoring, management, and the plan follow-up care post-treatment for patients needing GnRH analog therapy. This is today's agenda, and after my short introduction, I will introduce Professor Klein for her presentation, and then we will have hopefully 10 or 15 minutes for Q&A. So please enter your questions in the Q&A facility which you have, and we will of course address these, and I will ask Professor Klein to comment and answer your questions. And then, well, there will be a short post-webinar survey. Actually, the questions will come up in just a moment, and then I will conclude with some short closing remarks. The presentation has been accredited by the European Accreditation Council, and we would ask you please to complete your post-webinar survey, and on completion of the survey, you will receive a certificate of attendance from Medea. So this presentation is being translated simultaneously into Spanish. If you would like to use that facility, so please select your preferred language. And as I've said, please submit your questions, which we will do our best to address. So now there will be a short pre-webinar survey with some multiple choice questions, which I will read out in just a moment when they come up. The first question: Which of the following patients is least likely to need treatment with a GnRH analog for central precocious puberty? 6-year-old girl with stage 3 breasts and bone age 10 years, 8-year-old girl with stage 3 breasts and bone age 11 years, 8-year-old girl with stage 2 breasts and bone age of 9 years, or a 7-year-old girl with stage 2 breast development and a bone age of 9 years. I just give you a few seconds to complete these, and we'll go on to the next question. Okay, let's have the next question. And the next question is, which of the following is not true about the newer long-acting GnRH analog options? Efficacy is similar to short-acting GnRH analog options. Safety is similar to shorter-acting GnRH analog options. Initiation with monthly GnRH analog is important to increase the rate of suppression of puberty prior to switching to a 6-monthly analog therapy, and a single dose is appropriate for all children with CPP, even the very young at 2 or 3 years old. Okay, if you just take a moment to think about those and answer them. Okay, let's go on to the third question. Third question, which is least helpful in assessing pubertal suppression on treatment? LH levels post GnRH injection, rate of change of bone age maturation, clinical exam of pubertal staging, or height velocity, which is least helpful? Okay, so let's go on to the fourth question. Please rate your confidence in deciding which GnRH analog option to prescribe: excellent, very good, adequate, needs improvement, or poor. And the final question, please. And the final question, please rate your competence in managing follow-up care post-treatment for patients needing GnRH analog therapy: excellent, very good, adequate, needs improvement, or poor. So thank you for completing those questions. And it's now a great pleasure for me to introduce Professor Karen Klein. So, Karen, thank you for your presentation entitled Choice and Initiation of GnRH Analog Therapy for Central Precocious Puberty with emphasis on long-acting administration. Thank you very much, Karen.
Thank you for that nice introduction and background, and welcome to everybody. I am so excited to be with you and interact on this, one of my favorite topics, and around the world discussion. Here's my faculty disclosure. And you've already heard the learning objectives, but just again, to understand the indications for initiating GnRH analog therapy, the scheduling and different dosage options. And then we'll talk about monitoring, managing, and planning the follow-up care post-treatment for patients needing therapy. I know you've already heard two other very excellent webinars, but just to be on the same page for today, we'll define precocious puberty as follows. It needs to be both early, less than 8 years in girls. There's some debate in the 6 to 8-year-old girls, whether they are slowly progressing, early, normal, slowly progressing precocious puberty. Less than 6 years is not really debated for the definition of early. Less than 9 years in boys is pretty standard around the world. We can discuss that further in the Q&A if you like. And then it needs to be rapid. So it's not just early, since we know that there are some slowly progressing forms, but it also needs to be rapid. So in general, advancing more than one physical stage of puberty per year and having a bone age more than 2 standard deviations advanced and advancing more than 1 year per year. So not just a slightly advanced bone age that is always consistently about the same amount advanced, but actually seeing that there's rapid progression. And again, we can discuss that if you have differences of opinions or questions about how to manage that. And I think one of your free survey questions helped to sort of get at that question. And then growth rate consistent with the stage of puberty. So in girls, their growth velocity increases more early in the pubertal development and in boys later. So let's just look at an example, an obvious early onset at age 6. This young girl is growing very rapidly. You can see the increase in her height velocity. Breasts or testes, if it was a boy, would be increasing. And then the bone age shown by the triangles on the graph is advanced more than 2 standard deviations. And if someone is not treated, this is an example of how the height is nice and tall. Parents might not even be concerned. But if the bone age continues to rapidly accelerate, so you can see it was 3 years advanced, then 4 years advanced. And so then there's not a lot of time to finish growing. And while this girl reached a good height of 155 centimeters, she was shorter than expected for mother or father or mid-parental height. So why would we treat? The benefits that are often discussed are to normalize adult height for the family. However, have the caution that you need to know how tall the parents are and when they had puberty, because improvement in growth is multifactorial. Growth slows down on treatment, so the duration of treatment is very important. And we cannot help people be taller than their genetic potential, which is sometimes a question that many families raise when they come to us for evaluation. So we think about the benefit to adult height. Of course, there's always the benefit to stop menses. So even in someone where you're not concerned about height, if they are very young, 5, 6 years old, and already having menses, we can always use the treatment. It always works to stop menses. Psychosocial issues, bullying, depression, are higher in girls with earlier puberty. We have not had formal studies to see if treating decreases those. Of course, it's suspected it would, but not rigorously studied. Now, one other caveat I need to say with benefits and who we would treat is we always need to make sure that we look for pathology. So it's most important to see why is this child going through puberty rapidly, and is there any CNS problem, gonad problem, tumor somewhere that needs to be addressed. Once you define and treat any underlying causes, then we're discussing what is the benefit? Does this child actually need treatment or not? So when you look at the risks, well, there might not be any change in height, and there might be some detriment if you treated someone briefly and their height velocity slows down. We don't usually see it return post-treatment. So the duration of treatment, which we'll discuss later, is also very important. And then if the child is well adjusted, no psychosocial issues, there's also the risk of the stigma of treating and going to the doctor more often. And what's wrong with me if there is actually nothing wrong, but parents and physicians trying to weigh what is going on with the child, where are they headed, and is treatment of benefit? So let's take that same child, hypothetically, treat that child. So the girl who's growing very rapidly, has a very advanced bone age, starts treatment at 7 years of age. And you can see height velocity slows down somewhat on treatment because they're no longer in that pubertal rapid growth. But bone maturation also slows down. So the height for bone age, shown by the triangles, is improving over time. And this child then reaches almost 165 centimeters in height instead of 155, which is consistent with the mother's height. Here's a timeline showing the GnRH analog treatment options in the USA. I am so excited that we have 53 countries represented. So some of these are not available where you are. And there's others that are not available to me in the US that you have, but they're all very similar to these products. Monthly Leuprolide has been used in the US since 1993. We have a Hystrelin implant option since 2007. And then 3-monthly Leuprolide options, I think, are available in most countries, in the US since 2011. The Hystrelin implant, which is not available in a lot of countries, so we won't spend time on that today, but was approved in the US for changing yearly. But there's a lot of strong evidence now that it lasts longer than a year and maybe even longer than 2 years, for your information. And then in 2017, the triptorelin 6-monthly preparation became available. In 2020, a 6-monthly subcutaneous Leuprolide became available. And then just this year, another 6-monthly Leuprolide, 2 different manufacturers of those products. So looking back at this review, which I was part of, an update by an international consortium, some of you may have also been involved or had your patients involved. And so there's just a couple highlights that when we started using GnRH analogs, we did weight-based dosing, and the newer, longer duration analogs are not weight-based, and we can discuss that later if you like. There's updated laboratory criteria, and we'll go through that a little bit today as well. But overall, there's less hormonal monitoring, and we'll discuss why. Looking at growth rate, pubertal suppression, and the slowing of the progression of skeletal age are clinical indicators of suppression and adequate treatment. And then there is this shift to the longer acting forms, which is why we're doing this part of the webinar and talking about the longer acting forms today. Subcutaneous GnRH is being discussed, and we have those options. There's still a lack of long-term outcome studies with most of the products, especially the newer products, because it takes time to get to final height and then to do post-treatment studies. There's also a greater usage of the GnRH analogs among the older patients, despite advanced skeletal ages, and we'll discuss some of that new data as well. So how do you decide which one to use? Well, the safety and efficacy in general is the same. LH is suppressed. There's long-term data with older preparations, but there's very few comparison studies. And so we have to be very cautious on how we compare the products. We just need to look at each individual product and then individualize our choices per the family, patient, and physician preferences. One of the things to consider, and we can discuss later, is the effect on follow-up and duration of treatment. So if physicians have visits every 3 to 6 months to assess physical exam, height, bone age, um, it is helpful to have the option to give treatment at varying intervals and titrate the dose with the shorter acting preparations. But with the longer acting preparations, we might be able to extend treatment longer. People are getting I'm sorry, tired of shots, and one more 6 month preparation will give you 6 more months at least of suppression. Whereas if you were having a child on monthly injections or every 3 month injections, it's not as easy to extend it once they get to that stage of life that they're close to their friends or in puberty and they're very tired of their shots. So a little bit, this is a busy slide, but I want to show you the main points of how we monitor treatment and why we talk about hormonal evaluation, which is very important to show efficacy, and all of the studies to show efficacy of these products do hormonal assessments as the key outcomes. But we also have the problem of the great fluctuation in pubertal levels and how we define that. So one of the things is how much can we look at random LH? And a pubertal random LH on treatment does not necessarily indicate lack of suppression. So when you think about it and you're looking at a child and deciding if they're in true central puberty, we think about random LHs greater than about 0.3, 0.2, 0.3 in most of the studies that are available is pretty consistent with true onset of puberty as defined by a post-aqueous or depot leuprolide stimulation test. However, on treatment, random levels often don't fall below that 0.3 level. Sometimes they do, but my first caution is not to just use that level as an assessment of suppression, but how to put it together with the overall picture. When we look at stimulated values, most studies define an LH less than 4 as a reasonable goal to say you have pubertal suppression. The practice in the US over time, many endocrinologists try to get that LH between 1 and 2 or so. However, I want to show you and have us think about not to just use a cutoff that hasn't been rigorously defined and to consider someone a failure of treatment. So the non-hormonal variables that we discussed, again, are much more important. And then in the graphs, you can see the similar patterns. So as the 6 month preparations became available, I'm showing you from the publications, the 6 monthly GnRH stimulated LH levels. So in this panel, focus on the dark blue line. Obviously, before treatment, LH levels are very high because that's the definition of being in puberty. And then notice by the first month on treatment, I put this big thick line at that level of 4, just so you can get the feel. Estradiol is the red line, so ignore that for now. And just look at this blue line. FSH is the green line, but you can see suppression to below 4. And I purposely made that line too thick because we don't want you thinking about real precise interpretation of these levels, but to notice that on average, on treatment, people are in general close to an stimulated LH around 2 throughout treatment. So that's for triptorelin up here on the right for the first leuprolide under the brand name in the US of Fensolvi every 6 months. Again, rapid suppression at the beginning and again below that level of 4 and closer to an average of 2. And likewise with the newest preparation of leuprolide 6 monthly. In the bottom panel, you can see the stimulated levels. This This study used both previously treated and naive patients. So the naive patients in the dotted line with the very high levels, and the previously treated obviously already suppressed. And you can see again, by 4 weeks into this treatment, the 6 monthly preparation, very adequate suppression, markedly below the 4, and again, closer to around 2. So I do want you to notice this rapid suppression, because even though it's a 6-month preparation, and some of you might ask, do we need to start with a 1-month option or a 3-month option and get them suppressed faster and then do a longer action? Well, no, by the data, when we give a 6-month preparation, you see rapid suppression. So you don't get any more benefit for that reason by starting with a shorter acting preparation. We can discuss any other reasons you might want to start with that, but it's not to get more rapid suppression. The suppression is the same. So I did an indirect comparison because, again, very, very cautious. There's no direct comparison studies that use all of these agents. So you need to interpret this chart and the next one very, very cautiously. But just to show that with the different 1 month, 3 month, and then the newer 3 options for 6-monthly treatment, the studies across the board are similar as far as number of patients who participated, as far as looking at pubertal exam and showing that there's either no progression of the exam or actual regression over time. Looking at growth, height velocity goes down to normal pre-pubertal rates in all of the studies. Again, not comparing directly the specific numbers, although they're very similar because each were in an individual study, but pre-pubertal growth velocities, which again is very important to keep in mind. We want that as a treatment effect, but it also means you need to treat long enough, which we'll get to. And then looking at the rate of bone age progression, bone age divided by chronological age is a nice way to see that. It's usually around 1.5 in truly rapidly progressing puberty. That's one of your indicators of treatment before treating, and then suppresses to levels 1.1, 1.2 over the course of treatment. Again, not direct comparison studies, but looking very similar. Same thing, if we look at the LH levels, which I already gave you the cautions, we can look at peak levels, basal levels, and again, we can't do direct comparisons, but you can see they're mostly defined as either less than 4 or less than 5 for peak levels. And then when we just are collecting our information, not defining treatment in the studies based on the basal levels, there is a proposal that a level of around 0.6 is about what we expect. And so maybe you can use that as one of your markers of adequate suppression. The other thing that's interesting, when studies are designed and they say efficacy will be defined by an LH level less than 4 at a certain point in time or throughout the study, then they define failures in the primary manuscripts. And so I've listed that here just to see the spectrum of how failures are listed. But for each of these studies, you can't just look for clinical purposes at whether their LH met that criteria. Because if the pubertal exam was suppressed and the rate of bone maturation was suppressed and the growth decreased to pubertal growth, then when we would be looking at that patient clinically, we would not call them a failure just because they had an LH maybe 4.2 to 4.8 or even 5.3 in this study. So keep that in mind. Hopefully this is making sense. We have too many people to interact as we go through the slides, but please keep track of your questions and we will have time for sure to talk about them in a little bit. So how do we put all that together for optimal suppression? So the physical signs of puberty suppress. At least no progression, if not regression. Decreased rate of bone maturation, now that can take, that can take 12 to 18 months, and I'll show you some of that data. So keep that in mind. If you don't see an immediate slowing of the rate of bone maturation, if you repeat that bone age at 6 months or 12 months, you might not see a lot of change and you might be concerned. That's why you need to put all of these items together. Normal prepubertal growth rate we've talked about, but again, that can take some time, although in all the newer studies, we did see that change over that first year of treatment. And then suppressed hormones, which we've mentioned, we need to do with caution. Maybe stimulated levels less than 4 is a good evaluation based on the studies done to date, and random LH less than 0.6. But again, put these numbers together with the rest of this information as just one number or one variable alone is not adequate to define lack of suppression. And then we're looking finally at overall improvement in predicted adult height if adult height is one of the reasons you're treating. So I want to go over a little bit of new data from our group looking at the importance of individualizing treatment decisions. We often like to have a nomogram or a flow diagram or a clinical care pathway that defines exactly what to do based on each number and each variable that I've been talking about today. But as I've been alluding to, we need to put the whole picture together. So this comes up when we're discussing about girls who are in that slightly older range. So it's obvious what to do if a girl is 2, 3, 4 years old. Most boys, it's obvious they need treatment because it's much more unusual to have idiopathic central precocious puberty in boys. But what about those girls who are 7 to 8 years of age, like in your quiz at the beginning? Some people have questioned over the years, do we really treat those girls or not? And what about continuing past a chronological age of 10 or a bone age of 12? Some of you might use these as, when do I stop treatment? Oh, we'll stop when your daughter's bone age is 12. Well, I am going to walk you through how we need to, again, think about each of these situations, because there are some girls who are 7 who have some early theolarchy, but they are not progressing rapidly and likely don't need treatment. There's other girls who are 7 who are already in the middle of puberty and have very advanced bone maturation, and treatment is appropriate to consider. And then looking at that change in predicted adult height, can that help us individualize our treatment decisions? So this shows you some background that there's been some variation in the literature of reasons for not treating girls who are older than 6 and others who report benefit in those children. And I would propose to you, as you know, when you look at any study, there's a variety of patients in this study. Really good, rigorous studies work very hard to make the enrollment very rigorous so that we are definitely capturing rapidly progressing precocious puberty. If you look through the studies in the literature, do they always define the bone age of onset more than 2 standard deviations, or just 1 year advanced? And do they have enough time to say that that child continues to advance further? So you have to be cautious how you interpret data and where that variability comes from. So here's one figure looking at the change in predicted adult height based on chronological age at the start of treatment. So were a few girls at 4, 5, and 6 years of age. You can see one 6-year-old did not have much change in height, but everybody else, these dots that I'm showing, you hope you can see my pointer, more than 5 centimeters, some more than 10 centimeters. Nice treatment efficacy for improving adult height over time. Now, look at the girls who start at age 7 or age 8, and there's quite a range, but everybody has some improvement except for a very few 8-year-olds in this particular group. And look again at, here's 5 centimeters. Most, or at least half of the girls gained at least 5 centimeters, and some even more than 10 centimeters gain, even if they started treatment at age 7. Now we'd have to look at each individual girl to see which ones gained the most and why, and I'll show you a little bit of that data. But this is first to give you data for why it's appropriate in some situations to treat girls even if they're already 7, 8, or even 9, but they were late to present to you and had a very advanced bone age, and still improve predicted adult height by about 4 centimeters. Now, when we look at the effect of chronological age in general, there's continued improvement in adult height over time as they get older and go through the study. And then when we look at change in bone age, what I'm showing you here with this circle again is once you get to that bone age of 12, and some people say stop treatment, again, if they're at a good height and they're consistent with their peers, their pubertal development, it may be very appropriate to stop treatment. But if they still have growth potential, just because the bone age is 12, 12 and a half, 13, doesn't mean they're not going to continue to gain predicted adult height. And again, more than 5 centimeters, and for many, even more than 10 centimeters. So there's a large range of height outcomes. We don't know what would have happened if we stopped treatment, because you can't continue treatment and stop it in the same individual. So there is caution in interpreting what I'm showing you. But this is data that does show one measure of potential continued treatment. And then the other caution I want to give you, one of the arguments for stopping treatment around age 10 years of age is because menarche occurs an average of 18 months after you stop treatment in most of the studies reported. And so if you're 10 years of age and you stop treatment and your menarche occurs at 11 and a half, that is typical and seems like a reasonable decision. But when you look at all the studies who followed to menarche, the range is from about 6 months to 2.5 or 3 years. So if that child is 10 years of age, you stop treatment and they happen to have their menses in 6 months. Now you've done all these years of treatment and they still have menses earlier than their peers. So caution not just using that to make your decision. Hopefully that makes sense, and I can clarify in the Q&A. One comment about height velocity, because this concern that you want to let them finish their growth spurt of puberty. Well, here's the long-term data with the 1-month Lupron preparations on the left, showing how that rapid growth, excuse me, that rapid growth prior to treatment slows down nicely to prepubertal rates throughout treatment. This line is the end of treatment, and on the average, there is no increased height velocity post-treatment. So do not rely on that. Every once in a while, you see some increased height velocity, which I'll show you on the next panel. But growth rate on average slows down until the end of growth. We looked at just our patient population, 20 girls who we had height data and menarche data, just to show you the individual data that on treatment, they're growing at quite a range. This is all the girls. And then at the end of treatment to menses, there's still quite a range. Some don't grow much after treatment at all. Some are still growing pretty well until menses. And then once they have menses, again, some girls still grow for a while and some slow down immediately. Very few. We had one girl who was from a tall family and who kept growing very rapidly, but just to show you not to count on that increased height velocity. So how long should we treat and when to stop? You look at the age, concordant with their peers, anticipating menarche could occur anytime in this range. Look at the parent heights and puberty and where they ended up. You look at the bone age. I mean, theoretically, since the bone age is advanced and that's our pathology, you would want to catch up to your bone age. Remember, we are not curing the rapid progression. We are just putting it on pause. So once you stop treatment, the bone age acceleration maturation is going to resume and you're going to start to lose height potential. So if you stop too soon and the bone, and you're thinking they're doing well, and then the bones accelerate, you could lose what you've gained during treatment. So also to think, we often don't get to the point that they truly catch up to their bone age because people do pretty well and get to an age where they're ready to stop treatment. But that just gives you a guideline to not stop too soon. Don't forget about this bone maturation issue. And then height, again, related to what we've already discussed, the family heights. If the growth rate is slowing, there's variation in our height measurements, no matter how hard we try with our stadiometers. I advise that we watch growth rate over a couple visits before you say it's truly slowing down, because there is variation. And you want to look at where they are again, put all the variables together. Where's predicted adult height? Do they need more time to just sort of stay at that slow, steady rate to gain the height that they lost prior to treatment? And remember that we don't usually see a spurt, an increased height velocity post-treatment. And that means that we could have loss of predicted adult height after the end of treatment. Treatment is stopped too soon. So I'll end with a few cases of the long-acting preparations. They haven't been in use for as long a period of time, but just to show, this was a 2-year-old, obviously with central precocious puberty, stage 3 breasts at 2 years of age. She did have a hypothalamic hamartoma and very advanced bone age. As you can see, here's her very tall stature for going into puberty early. Here's her very advanced bone age, therefore a short height. You would treat her anyway just because she's 2. So she started on a monthly preparation, which was available back then at that time, and did very well. You can see her height for bone age slowing very nicely. And then when it was available to switch to the Lupron 6-monthly product, she did so around 7 and continues to have steady growth. Now she's tall, so she's an unusual example to show you, but I wanted to show you one of my long-term patients. This is a real patient of mine. And so this growth velocity is steady. She's not accelerating further, and her bone maturation, she's actually almost caught up now and is probably going to be nearing the end of her treatment. But she continued doing well on the 6-month prep. Here's an 8-year-old girl who presented at age 7. Her height had increased from around the 50th to the 75th, and she went rapidly through puberty. Between 7 and 8, she went to stage 3 breasts, and her bone age progressed from what was about 1 year advanced to 2 years advanced. So here's another example of, would this child with a 1 year advance be someone who would do just fine? We watched her to see, and she grew faster. Her breast rapidly matured and her bones rapidly matured. And so she was started on a 6-month preparation in the US, the Fensolvi preparation, just to show you a variety of our long-acting drugs available. And her bone maturation slowed very nicely, and her growth rate did not continue to accelerate, but has that slight decrease that we expect. And then lastly, a 9-year-old who had breasts at age 7 and very rapid growth. She was short. She's from a shorter family. And so you can see very atypical that by 9, she had grown so fast. No one was worried at first. So this is a later presentation, but with a bone age 2 years advanced. She was started on treatment. And so far over her first year of treatment, with the Triptidar product, a 6-month product of triptorelin, her bone age has only advanced half a year in her first year on treatment. Her growth velocity obviously slowed down, to a normal rate, and we'll see where she goes from here, just to show you a spectrum of some of my cases. So in conclusion, who do we treat? It's very important to make an early diagnosis because the late diagnosis, we've lost potential growth. We look at bone age, chronological age, the rate of progression, the growth rate, the family puberty and heights. All of these are important to put together to decide who might benefit from treatment and to be thinking about why you are treating. Is it to stop menses? Is it to improve height? Is it psychosocial reasons? And again, not to miss pathology. That wasn't the point of this talk, but that's always what you look for first. And then which GnRH analog to use? So there's few comparison studies. It's hard to do them. Safety and efficacy is similar when you look at each individual study, but you have to be very cautious interpreting across studies. Evaluating the frequency of how often they need to come for visits or injections or implants, and decide with the family. The duration of therapy factors can be considered in the value of switching to longer acting products potentially. And then how to assess suppression. We talked about looking at multiple things, not just one variable, pubertal exam, the growth and predicted height, the bone age progression, the hormonal levels with the cautions that I showed you. And then when to stop treatment. Again, I really want to stress the individualizing that decision and not using one variable, no one age or bone age as an absolute, looking at height predictions and comparing the maturity to their peers, because you are helping them be consistent with their peers through their childhood years rather than maturing much more rapidly and all the things that come with that. So thank you very much for your attention, and I look forward to our Q&A time.
Great. Thank you so much, Karen. That was absolutely brilliant and a very clear and instructive presentation and highly clinically relevant. Thank you very much indeed. So we have quite a few questions. Can I just make one general point, and that is whenever I hear a real expert talking about a topic, it's not that straightforward. And I always get the impression that a child with precocious puberty, it's so important that they see the same clinician each time they come back. Do you agree with that?
Well, I think that's always helpful in knowing our patient and being able to put all these variables together that we're talking about and not just using one number,
Yeah,
right?
yeah,
So I do think that's a good point to make. And also, we know the variability in our height measurements. And I always think, I am much more consistent with myself. I do all my own height, so I can assess,
yeah, yeah.
growth much better. And so that changes clinician to clinician. Reading the bone age changes clinician to clinician.
That's right.
More and more countries maybe on this call are using automated bone age readings, which we need to collect more data to see if that helps. But yes, keeping the same person reading the bone age, because the absolute bone age might not really predict as much as that change in bone age over time.
Sure. Okay, so there's a question here. Is there a difference in the duration of the response or efficacy of GnRH agonists in girls with obesity or overweight?
That's a
So, do,
yeah, that's a very interesting question. And the studies that have been done to date, I believe most of them for sure did not include overweight or obese children, so that we don't have a confounding variable. Because, of course, the first goal of the study is to prove efficacy in general. And there is a potential confounding variable related to weight. And we know that just gaining weight rapidly can mature bone age more rapidly. And in all of our patients with our obesity epidemic, we want to talk about healthy lifestyle and work with our families on not having rapid weight gain because there could be an added maturation of the bones while we're trying to assess are we suppressing puberty. Also, that brings up the very difficult exams sometimes of distinguishing
Yes.
adiposity in the breast area from true breast tissue. And so you have
Yes.
to be cautious that you're not thinking it's treatment failure. So, one answer to your question is we don't have a lot of data, but I've just given you some things to consider when you have your individual treatments. As far as the duration of treatment, you would use the same variables to
Yes.
decide.
Yes. Yes. Thank you. Is there a difference between monthly leuprolide or triptorelin, or would you choose the available presentation, whichever one is most available?
So again, there's no head-to-head comparisons. There might be a few smaller studies actually on that particular question. We're talking about the 1 monthly preparation. Um, there might be one publication. I didn't bring that data, and we could look at it, but there's not long-term a lot of data, and so based on what I've presented to you today, whether it's triptorelin or leuprolide, um, we don't have a way to say there's a major difference between the two preparations.
Okay. Okay. Now, can I ask what would be your timetable for monitoring and, say, performing a GnRH stimulation test to assess suppression? So you start the patient on a 6 monthly preparation. How often would you monitor the degree of suppression?
So obviously, to do the clinical studies, we monitored very closely and did 1 month and 3 month and 4 and 5 and 6 month in some of the studies to prove the efficacy of that 6 month duration if we're going to focus on the longer acting
Okay.
agents for this question. Um, and so always you can do a GnRH stimulation test. And in the clinical studies, that's what was done to show that there's good suppression because that's as close to our gold standard for hormonal suppression as we can get. Over the longer term, we follow all the clinical variables. And I think I've stressed that today is that when you see those patients, that's what you're looking at. Now, how often should you look? So once you start treatment, um, usually we recommend, at 3 months after whatever treatment it is. If it's a 3 month preparation, you can see them at 3 months for their second injection, and you can do a post injection LH level as a pseudo stim test. There's good data looking at that.
Okay.
If they're on a 6 month preparation, I think most of us would still see them at 3 months to make sure things are changing, just looking at their clinical exam and their growth, even though we have to interpret it with all the caveats I said.
Yeah.
And I do a random, just basal level of both LH and estradiol in a girl or LH and testosterone in a boy at that point to give me an idea to put together with my other variables. If I'm worried based on, they're still very moody or they're still growing so fast or their testes have increased in size or their breast exam has really changed. And I don't expect that, even though I don't expect a lot of changes of regression by 3 months. I don't want them to be still progressing at 3 months.
Right.
Then I might do a GnRH stimulation test at that point if they're on a 6 month prep and I can't use the drug as my stim test. But if all
Right.
looks good at 3 months, then at 6 months, I do hormone levels after that second injection, because
Okay.
again, that is a stimulation test, um, as best we can interpret, to add to all the other things. And I look at a bone age. After they're proved to me at 6 months that they're doing well, then I see them every 6 months, which is a benefit of having the longer preparations, and do a bone age at least once a year. I do it more often if I'm worried. Are they growing faster? Does the parent think they're a little more moody before their injection? And I do hormonal levels based on the same things. How concerned am I? Most children do so well. So even when we looked at, there's always some failures. Are they true failures? We know there are sometimes some true failures, but overwhelmingly 90% in general do so well that once you've proven suppression, um, then seeing them every 6 months and just assessing growth and bone maturation every year, I think is a very reasonable thing. Obviously, altering it as needed.
Sure. I think it was very important that you mentioned the non-hormonal variables in terms of assessment of their progress. So basically, height velocity, body composition, clinical breast development. And I mean, usually the mother will tell you if you know the treatment appears to be successful or not.
Yeah,
So
they often know they have their little girl back, or,
yeah,
oh, this
yeah,
is so much better now. Yeah.
exactly. I think that's really extremely important. Um, let me see. Goodness, there are many, many questions. I'm going to choose two more. Um, okay. Is there an option to treat girls who begin puberty at 9 and progress fast to Tanner 4 in 1 year?
That is an incredibly interesting question to me, because obviously it's not that something magic happens at your 8th birthday,
Yeah,
and that if you had puberty before 8, there's something wrong, and after 8, there's nothing wrong. We are looking at a spectrum. We don't completely understand the pathophysiology. With
yeah,
all the new studies of MKRN3 mutations or kispeptin mutations, we're going to learn a lot more of the genetics. And once we can routinely test for that, if you know you have an MKRN3 mutation and that's the cause of the rapidly progressing puberty, and it just wasn't picked up till 9, I think that's going to be a very interesting discussion. I very much want to study this group, but it's difficult, and I'm working on trying to get funding. If any of you have any options for this or want to collaborate around the world, because we would have to do it very rigorously. So first of all, we don't have the data, so I can't really answer your question. But I want you to think about the theory of it, that certainly there could be a 9-year-old who is progressing so rapidly. So I'll give you one real example. I have a patient who went through brain surgery at 9 and made her puberty accelerate so rapidly. So I have a reason why she's accelerating rapidly. We've removed that balance of stimulatory and inhibitory neurons and that hypothalamus, theoretically. And so I have a reason to treat her that's off label technically, but makes sense. So you want to think
yeah,
about what you're doing. If we're just trying to improve height modulation, we know from some indirect studies that that is difficult to do. It's and we can't expect to change the trajectory of familial genetic predispositions. So
yeah,
keep that in mind. I think where we need to consider this is when it doesn't fit with the family and where it is really rapid. And then if we define that population very carefully, then we could study it to get this answer. But right now it would be anecdotal. And my biggest caution is have a reason, make sure it's not just a family pattern, make sure you're not just trying to make someone a little bit taller, because there is a range of when people go through puberty. There's some very tall people who go through puberty very rapidly, but they
yeah,
keep growing after menarche, like inches, and not just 2 inches on the average that we say. But
sure.
I have one girl grew 6 inches after menarche because she was from a tall family. She
Yeah,
obviously didn't need treatment, looking back in time. So
yeah,
hopefully that doesn't answer your question, but
yeah.
interesting thoughts.
Thank you. Can I just finally ask you one very brief yes or no? Any place for growth hormone treatment in children with precocious puberty?
It's not a yes or no question, sorry to say, but I'll be brief because we're almost out of time. If they have growth hormone deficiency, of course, treat them.
But if
You
they
could
don't?
have central precocious puberty. If they don't have growth hormone deficiency, data so far does not support adding growth hormone just to
Okay,
try to get better growth.
right. Okay, that's very, very helpful. Very helpful. Now, in fact, there are many questions, and we will actually email them to you. And if you have time, it would be fantastic if you could just look at them briefly and respond briefly. That would be extremely kind.
I would be
So
happy to do that.
thank you so much. Well, thank you again, Karen, very much indeed. We've actually completed now the series of live webinars on central precocious puberty. In the first webinar, we looked at the awareness of central precocious puberty amongst the range of disorders of growth and puberty that we all see every day in clinical endocrine practice. In the second webinar, we looked at the critical criteria for identifying children who would eventually benefit from GnRH analog therapy. And in the third webinar you've just heard, Karen Klein has given us a very clear and comprehensive picture of the management of CPP with GnRH analog therapy. So it's been a privilege to share this educational event with you. I'm extremely grateful to Karen for her beautiful lecture, to the organization by Medea and the team, and also, of course, we are very grateful for the sponsorship from Ipsen. Don't forget to complete your post-webinar surveys. There are lots of comments coming in that this was a very helpful and useful session. Thank you for those. And when you complete your survey, you will receive your certificates. So thank you again. It's been a privilege reaching out to you in 53 countries. And I hope very much that you have enjoyed and benefited from this important educational event. Thank you and goodbye.